First, we're going to talk about primary headaches. And primary headaches means it's a headache by itself. In other words, it's not caused from another condition. Throughout this lecture, I'll be talking about other conditions that create secondary headaches. But for now, we're going to talk about primary headaches. And there's three types. There's migraines, cluster, and tension type headaches. I'm going to go into more detail with migraines and cluster headaches. Tension type headaches usually produce mild to moderate pain that is band-like around their head, and it's bilateral. In other words, it's on both sides of the head. And shoulder, they'll have like muscle tightness, shoulders, neck, and back. So they're really tense, and it's often associated with lack of sleep. So somebody that's really tense, okay, would suffer from tension type headaches. Migraine headaches have four stages, and I'm not going to go into too much detail with the stages. But the first stage, like any illness, is prodromal phase. And this can happen 3 days before or hours before the migraine headache. Some migraines last up to 4 days. Okay, so the prodromal syndrome would be like having food cravings or sensitivity to light, sound, and odor. The second phase of a migraine is the aura. So it's kind of like a warning aura, and typically what happens is this could happen 60 minutes before the migraine headache actually happens, and they'll have visual difficulty, like they may have like blind spots or tunnel vision. They'll have extreme fatigue and weakness, like in their upper extremities or in their limbs, and numbness and tingling of their extremities or circumoral numbness and tinglings. When they get the final headache, it's a throbbing pain, usually affects one side of the head. So the term for that is unilateral. However, in some cases it can be bilateral. It'll be accompanied by nausea and vomiting, photophobia, which means that light hurts their eyes, and phonophobia, which is an adversity to sounds. So those are the signs and symptoms. Okay, this is the characteristics of a migraine in mnemonic form. So pound is the mnemonic, and you can remember migraine gives me a pounding headache. P is for pulsatile, which means throbbing. O is for the hours, 4 to 72 hours a migraine can last. That's a long time to have a headache. U is for unilateral, so one side of the head. N is for nauseating, which really means they can get nausea and vomiting while they're having a migraine. And D is for disabling. If they ever having a migraine for 72 hours, they're not going to be able to do anything but rest in a cool, dark room for 3 days. The triggers for a migraine are highly tested. So they include sleep, a lack of sleep, and a lack of eating, like somebody that skips meals. Alcohol, that can cause migraines, especially like, Chianti wine that contains tyramine, because that can also increase the chance of a migraine. Hormone level for women, so it could be around their menstrual cycle. Eating nitrate rich foods and tyramine foods, so you should remember those from pharmacology. Using artificial sweeteners, intense odors, and bright lights. Any kind of weather or altitude changes can also cause a migraine headache. Okay, taking care of a patient with a migraine involves teaching them stress reduction. So they, teach them to go to yoga, get a massage once a week, do Tai Chi, whatever is going to reduce stress in their life. You want to encourage them to keep a headache diary. In other words, write down what they're eating, write down what they think their triggers are so that they can identify the triggers. There's also a genetic component to migraines, so maybe explore their family tree and see if there was somebody in their family with migraines. You want to reinforce teaching about over-the-counter medications, like if they're having a mild migraine, they might be able to get by with ibuprofen or acetaminophen. Herbal products have proven not to be successful in treating migraine, so you might have to have a conversation if they are taking herbal medications just, you don't want them to do anything that's not going to help with their headaches, okay? You want to explain to them once they get a headache, they should go into a cool, dark environment. They should keep their head abed 30, and then use the abortive therapies such as triptans, antiemetics, and ergotamine. So ergotamine has the caffeine in it, which helps kind of vasoconstrict, and same with the triptans. Now, just be careful with the triptans if somebody has cardiac disease, because it vasoconstricts and it could vasoconstrict the coronary arteries. So recognizing cues with cluster headaches. So unlike migraines, cluster headaches are more common in males 20 to 50. They do not have an aura, but they do go into remission for a brief period of time after they have some cluster headaches. So with the cluster headache, they can have like several a day. So that's why it's called a cluster. And it causes unilaterally, so that means one side of the face, usually behind the eye, intense severe pain. There'll be redness and swelling of the eyelid on that side, tearing of the eye, and facial sweating. They will also have constricted pupil, and they occur multiple times a day. I think I mentioned that. The triggers for cluster headaches are alcohol and smoking. And they're also more common in the fall. Okay, the treatment for a cluster headache is very similar to a migraine headache. The medications are the same. You want to tell them when they get the headaches to go to a quiet, dark, cool room, just like a migraine. Head of bed 30. You want to encourage them to engage in activities that result in stress reduction. It's found that an altered sleep-wake schedule is another trigger for cluster headaches, so you would educate about that. Then the other thing that's different for migraines is that oxygen therapy helps. So it's 12 liters a minute times 20 minutes, and you would have the patient sit up while they're engaging in oxygen therapy. So that's it for cluster headaches. These are the risk factors for seizures, and you can use the mnemonic vitamins. Now, you don't need to memorize this or anything. What I'm trying to show you here is that most of the conditions on this list we're going to be talking about for this first exam, okay? Like, for example, vascular. People that have stroke are going to be at risk for seizures, especially 24 hours after to 72 hours after. People with arterial venous malformations are at risk, especially if they burst and they have a subarachnoid hemorrhage. They could have seizures because it's irritating to the cerebral spinal fluid. People with infections, that's one of the most common causes of seizures. So we're going to be talking about meningitis, and people with high fevers also are prone. And then with trauma, we're going to be talking about traumatic brain injuries, a cerebral edema that can happen with them. It can also happen after surgery, like a craniotomy. Anoxia happens like in a drowning accident. There's no oxygen to the brain. It cannot survive. Um, and then the other ones we'll be talking about are neoplasms, which are brain tumors. Now, some other things that can cause seizures is substance abuse withdrawal. So, for example, alcohol withdrawal or barbiturate withdrawal. Those are the two types of illicit drug withdrawals that need to be medically monitored, okay, because they can have seizures. And then people that stop taking their seizure medication suddenly can have rebound seizures because they stop taking their medication. In addition to risk factors, there are seizure triggers. So these include like increased physical activity. So people that exercise to the max, excessive stress in your life, hyperventilation. You learned last semester when somebody's having a panic attack and they hyperventilate, they get respiratory alkalosis. Well, that can make them more prone to seizures. Acute alcohol ingestion. So, like getting a little tipsy or drunk can trigger a seizure. Excessive caffeine intake, exposure to flashing lights, and drugs such as stimulants like cocaine. Hyperventilation, I want to go back there because patients often have a ECG to diagnose seizures. And one of the things that they make the patient do during the test is they have them hyperventilate, and they may also ask them to be sleep deprived, but they may also expose them to flashing lights to see if they can trigger a seizure. So those are seizure triggers. This is some seizure terminology because there's a lot of different types of seizures, and if you can know the basic words, you can kind of figure out what the characteristics are. So A means without, I think you know that. Tonic means stiffening of the muscles. So if you have atonic seizure, that means the muscles lose their muscle tone. Okay. Clonic means rhythmic jerking of the extremities, whereas tonic is stiffening of a muscle. Okay. Generalized seizures involve both cerebral hemispheres, and there's 5 different types. Focal seizures or partial seizures are only involve one hemisphere. And then status epilepticus is a medical emergency. This means somebody is having a seizure for longer than 5 minutes, or seizure activity just keeps repeating within a 30-minute time frame. Your job is going to be to maintain the airway and make sure your patients that are at risk for seizure always have a patent IV. You are going to flush that first thing when you come in on shift to make sure it's working if they have a saline lock, because you don't want to have to try to put it in an IV when somebody's seizing. And with status epilepticus, what they're going to give them is lorazepam or diazepam to stop that seizure, and they may need a lot of it. Okay, so that's some seizure terminology for you. Clients who have generalized seizures usually have a warning or an aura before they have a seizure. So that's like an alteration in sensory function, like they have alterations in smell, vision, or hearing. Uh, there's 5 types of generalized seizure. The first one is probably the one you think of when you think of seizure. It's a grand mal seizure. It's called the tonic-clonic. So the tonic phase, remember, that's the stiffening of the muscles, only lasts a few seconds. And then the clonic, which is the rhythmic jerking phase, lasts about 2 minutes. Then tonic is they do have a loss of LOC, same with tonic-clonic. And then clonic is the rhythmic jerking by itself. Myoclonic is brief jerking and stiffening of the extremities. And then atonic means loss of muscle tone. So if somebody's walking, it could result in falling. And then absence seizures, this typically happens in children, so you'll learn about that in pediatrics. If you have a patient on seizure precautions, ensure you have airways like an oral airway or a nasopharyngeal airway. And remember the difference. The oral airway can only be put in unconscious patients. So like when they're postictal, if they're still unconscious, you may have to put in an oral airway. Nasopharyngeal can be put in conscious patients and unconscious patients. You do not want to insert these during a seizure, but you may need them in a postictal period. Postictal means after the seizure, because patients are usually very sleepy and tired. You're going to check that the suction is set up. And not only that, this is my pet peeve, make sure the suction is working before you need it. Oxygen, make sure it's readily available. Make sure you have everything you need in case you have to put oxygen on your patient. Make sure your IV line is always patent. And we never use padded tongue blades at the bedside anymore. We don't put anything in a patient's mouth while they're seizing. Okay, this should just be review from fundamentals about what to do if your patient does have a seizure. First of all, don't leave your patient. Always stay with your patient and call for help. Place the patient on the side, lower them to the floor, slide them to the floor if they're sitting in a chair or they're upright when they start seizing. Lower them to the floor. Put them on their side if you can to protect their airway. Move all furniture and objects out of the way to keep the patient safe. Place the head in your lap or a rolled blanket or a towel. You got to protect the head. You want to have O2 on if necessary and suction PRN with not a yank power with the flexible suction cap. Don't attempt to insert an airway during the seizure or place anything in the mouth or nose. Do not restrain the patient. You can loosen clothes around the neck if need be, and note what the patient was doing when the seizure began. Reorient the patient PRN. When they are postictal, and that's the period after the surgery, they need a private room and a lot of sleep. So make sure they're placed on their side when they're postictal and they have some privacy to sleep. Now we're going to talk about traumatic brain injuries. People that are at risk include males are at risk because they do stupid stuff. And then people that drink alcohol and do drugs and then do stupid stuff. Older adults, they're going to be at risk because, they take a lot of medications that could make them drowsy or dizzy. And they also can be all blood thinners, so it makes them at risk. And they're at risk for falls to begin with. People with psychiatric or cognitive disorders are more at risk. And those that engage in contact sports, so sports injury, they're going to be high risk for TBI. The most common cause of TBI is falls, them being struck by an object or being involved in a motor vehicle accident. So traumatic brain patients, injury patients are going to need cervical spine x-rays, possibly an MRI, CAT scan. They're going to have a cervical collar when they come into the ED, which cannot be removed until the provider says it can be removed, and that's to protect their spinal cord. Anytime you have a head injury, you check for spinal cord injury. Anytime you have spinal cord injury, you check for head injury. So an open TBI may appear at your ED, and they're going to be an infection risk. So we would watch them closely for signs of infection and septic shock. With a closed traumatic brain injury, we worry about brain herniation, which occurs because there's only so much space in the skull, and the skull is rigid, so the skull cannot move. So there's only enough room for the brain in there. Now, if you have a TBI and somebody has a hematoma or you have a brain tumor, the brain's got nowhere to go inside the skull. So the brain may start herniating, meaning it may start shifting, okay? And this is going to cause increased intracranial pressure inside the skull. There's different levels of TBI, and the first one is the most mild, so it's a mild TBI. It's also known as a concussion. Patients with mild TBI or a concussion, there's usually a change in neurological function, but no brain damage associated with it. Usually resolves in 72 hours. They're treated and treated based on their signs and symptoms when they present usually to the ED. They're going to need lots of sleep and rest, okay, and a gradual return to their ADLs. Now, the Glasgow Coma Scale will be scored as 13 to 15, and I had gone over the Glasgow Coma Scale in the A&P and assessment lecture, okay? They may or may not lose consciousness if they have a mild TBA. They are definitely going to complain about headache or pressure. They may have amnesia, they may not. They may lose consciousness, they may not. They may complain of dizziness, nausea and vomiting, confusion, and they'll be sluggish. Another concussion within 10 days could increase the risk of brain problems, and they may have problems with memory and attention for up to 4 weeks. So a contusion means there's a part of the brain is bruised, okay? There's going to be a period of unconsciousness. The patient will have stupor, be confused, so watch out for increased intracranial pressure. A basilar skull fraction can occur during a TBI, and this is not picked up on a CAT scan or an MRI, so you have to use your nursing spidey sense. Most patients, all patients that have a TBI, they come to the ED, they're going to get a non-contrast brain CAT scan. The reason they don't use contrast is because contrast shows up as white on the CAT scan result, and so does blood. So they do non-contrast to look for a hemorrhage first. But anyways, back to basilar skull fracture. So it's diagnosed by CSF leakage through the nose and the ears. The patient may have bloody or clear drainage coming out of the nose or the ears. So if it's coming out of the ears, it's called otorrhea. If it's coming out of the nose, it's called rhinorrhea. It could be bloody or clear, and you need to do a halo test. So the basilar skull fracture is fractures on the baseline of the skull. Okay, so remember that, and I'm going to show you what it looks like in a minute. These are pretty obvious signs of basilar skull fracture. Raccoon eyes, and then bruising behind the ears is called battle sign. So those are cardinal signs too. With halo sign, you take the fluid that's leaking from either the nose or the ear, and you put it onto a white gauze pad, and in a few minutes the blood collects into the middle of the center, and then there's like concentric rings of cerebral spinal fluid. So that's how you tell. Another thing you can do is a glucose dipstick to see if there's glucose in it, because your mucus doesn't have glucose, but your cerebral spinal fluid most definitely does. Now the preferred method is always going to be halo sign first, but I'm just telling you the other option is testing it for glucose. If you have somebody with a basilar skull fracture, you want to manage the leakage of CSF, cerebral spinal fluid. So head of bed needs to be 30, no pillow, because you don't want the neck to flex, okay? Because if you have any flexion, like with the head and neck, the patient could increase intracranial pressure. So you want the head and neck in proper alignment. So the head of bed 30 and the head and neck just straight, not flexed. Okay, so that means so the cerebral spinal fluid can drain from the head. You may put a mustache dressing or an ear dressing, keep it sterile. No blowing nose, no picking nose. You're going to have to teach them that. No coughing or sneezing. Never plug up the ear or nose. No hip flexion. If they have a fever, you need to be very diligent in treating it, because temperature increases intracranial pressure. So you have to treat that quickly. Everybody that is at risk for increased intracranial pressure needs a stool softener so they don't strain when having a bowel movement. And they need pain control, because that may increase intracranial pressure as well. All right, next we're going to talk about hematomas. They can result from traumatic brain injuries as well. An epidural hematoma typically occurs there's an injury to the temporal region of the head, okay? And it's usually due to damage to the middle meningeal artery, and it's arterial bleeding, so you have to act really quick to recognize this, because arterial bleeding is fast bleeding, right? They could really bleed out. The hallmark sign is the patient will be unconscious. They'll have a lucid interval, meaning they'll regain consciousness, and then they'll be unconscious again, and usually it's downhill from there. So you need to be able to recognize it so the patient can go to the OR and get it evacuated. Okay, in this slide, we're going to compare epidural bleeding with subdural and intracerebral, because these three types of bleeds can happen during a traumatic brain injury. So epidural, we talked about earlier, it's arterial bleeding, so it's fast bleeding. And so we need to recognize it early so we can get the patient to a CAT scan and then to the ED. Okay, I'm not the ED, the OR. So with epidural, the cardinal sign is first the patient's unconscious, they become lucid, then they become unconscious again. So there's a rapid decline in LOC after that lucid interval. They'll have nuchal rigidity, which means stiff neck. And the reason is anytime blood is in the brain in a space it's not supposed to be in the cerebral spinal fluid, it irritates the cerebral spinal fluid, and they have what's called meningeal signs, such as stiff neck, nuchal rigidity, seizures. They're going to have a headache because they have a traumatic brain injury, nausea and vomiting. With epidural, they could have periorbital ecchymosis, because remember, it's on the temporal side of the head that they have the TBI, and usually it's from a bleed of the middle meningeal artery. All right, they will have a blown pupil or a dilated pupil on the ipsilateral side. So anybody with a brain bleed, if they have a brain bleed, the pupil can become dilated, because the brain is pressing on cranial nerve 3 on the same side, ipsilateral side of the injury. Okay? They could have contralateral hemiplegia, so contralateral weakness. So watch out for that. Subdural hematoma is venous bleeding, so it's a little less worrisome, but still, we still worry about it. Okay? It can be acute to subacute to chronic. So chronic, it can take like up to 2 months before somebody starts having symptoms from a subdural brain bleed. So I took care of a patient once, and I think it was February. She was out shoveling snow. She fell. She hit her head. Forgot all about it, and I think it was about May she came into our ICU with the subdural. Okay, so oftentimes they have to think back to when they fell. That's chronic. Subacute, the symptoms would occur probably about a couple weeks after, and then acute would happen right away. So people that drink a lot of alcohol and older adults are going to be really at risk. And the reason is that alcohol shrinks your brain, and getting older shrinks your brain. So there's more space in between the skull and the dura mater. So it's a place where slow bleeding could collect over a long period of time. So again, they could have a dilated ipsilateral pupil. They could have contralateral weakness. So you'll be looking for that. They'll complain of a headache, obviously. And then severe neurodeficits can occur as well. And they need to go for a CAT scan. And then with intracerebral, this is usually due to increased intracranial pressure, a blow to the head, a small artery burst, like an AVM, that stands for arterial venous malformation. Sometimes people are born with these, and they're very weak. So over time, it could burst, okay? So the aneurysm could burst. So that's just a comparison of 3 different types of brain bleeds. Subarachnoid hemorrhage can happen for a few different reasons. It could be due to an arterial aneurysm or an arterial venous malformation. Occasionally, it could be due to trauma. It could be due to like really high blood pressure and somebody has an AVM and it just bursts. Typically, patients present with the worst headache of their life and meningeal signs. And the reason they have the meningeal signs is the subarachnoid space is where the cerebral spinal fluid is housed. So when somebody has blood where it's not supposed to be in the brain, they're going to get meningeal irritation. So they'll have stiff neck, nuchal rigidity, headaches, photophobia, seizures, and nausea and vomiting. Anybody with the subarachnoid hemorrhage is going to be at risk for rebleeding 7 to 10 days after the bleed. So you need to keep them quiet. They're going to be at risk for increased intracranial pressure. So we'll be learning about those interventions. So you're going to make sure the patient is in a nice, quiet room. For subarachnoid hemorrhage, we're going to do all the interventions that result. You want to make sure that you're doing all the interventions to prevent increased intracranial pressure, and that to prevent rebleed, the patient is on nimodipine, which is a calcium channel blocker, which helps prevent rebleed of the subarachnoid hemorrhage, because calcium channel blockers result in smooth muscle relaxation and vasodilation. And the rebleed is usually due to a vasospasm. The warning signs after a head injury, we're looking for increased intracranial pressure. Even somebody that has a concussion, so they have a Glasgow Coma scale of 13 to 15, you're going to warn the family about these type of signs and symptoms so they can bring the patient back to the ED if necessary. People with moderate TBIs have a Glasgow Coma scale of 9 to 12, and severe is 8 or less. So with that being said, we're looking for increased intracranial pressure. So the first sign of increased intracranial pressure is a change in their LOC. Maybe they're becoming disgruntled. Maybe they have apathy. Something that there's a change in their LOC. Usually it's drowsiness, confusion, and they're difficult to arouse. So you want to catch that early. Pupils is a little bit later. So they may be slow to react or unequal, or you may have that dilated pupil on the ipsilateral side of the brain injury. They could complain of double vision. maybe their extraocular movements are not moving, so you would check that. They're at risk for seizures, and we're going to check for bleeding or drainage from the nose and ears because they could have had a basilar skull fracture. Check for slurred speech, projectile vomiting. That's a sign of increased intracranial pressure. Preventing increased intracranial pressure, you're going to use these interventions on anybody that's at risk for increased intracranial pressure. For example, like somebody with a traumatic brain injury, somebody with a stroke, somebody with meningitis. We want to prevent increased intracranial pressure. There's a lot of reasons somebody could be at risk for it, right? So everybody that is at risk needs to be taking a stool softener because you don't want them to strain when they have stool, okay? And then you want a quiet environment. You want to dim the lights in the environment because they could be photophobic. You want to reduce fever with acetaminophen because the temperature is going to worsen intracranial pressure. It's going to increase intracranial pressure. Avoid flexion. Avoid hip and neck flexion. Don't let them use a pillow. Maintain normal body temperature. No coughing or sneezing. Make sure you're giving them antiemetics because you don't want them to vomit and strain. Head of bed needs to be 30 and the neck needs to be in a neutral position. Keep the room dark. Make sure you're giving oxygen to keep the PaO2 over 60 because hypoxemia, hyperthermia, and a low blood pressure are going to increase intracranial pressure. I talked about increased intracranial pressure in the A&P and assessment lecture for neurological function, but the normal intracranial pressure should be 10 to 15 millimeters of mercury. It's measured by an external ventricular drain. I don't expect you to know how to operate it. I'm just pointing out if somebody does have this, they're going to be at risk for meningitis. Anybody that has drains in their brain or has an open TBI or basilar skull fracture, they're going to be at risk for meningitis as well. Okay, recognizing cues of increased intracranial pressure. Your patient's going to have the first sign, a change in their LOC. They're going to be irritable. They could be. They could have restlessness. They could become very lethargic and have decreasing level of consciousness. That's usually the first sign. They could complain of a headache. They could have projectile vomiting and nausea. They could have a change in their speech patterns or they become aphasic. Pupil changes. We talked about that ipsilateral dilation of the pupil on the same side as the head injury. So ipsilateral. Cranial nerve dysfunction. So be looking for cranial nerve dysfunction. They could have ataxia, which is uncoordinated walking. They could have seizures, which is a late sign, and also Cushing's triad and posturing are late signs. Cushing's triad is bradycardia, increasing systolic blood pressure, so there's a widened pulse pressure, and a change in respiratory pattern. In posturing, I went over in the assessment lecture with the A&P. This is just a picture showing you what I just talked about the signs and symptoms of increased intracranial pressure. Make sure you can distinguish early signs from late signs. Again, a late sign of increased intracranial pressure is Cushing's triad. Increased systolic blood pressure, decreased pulse or bradycardia, widened pulse pressure, and change in the respiratory status or pattern, and also decreased respirations. Shock, on the other hand, and this is septic shock, hypovolemic shock, they're going to have a low blood pressure, increased pulse, so tachycardia, and increased respirations, so tachypnea. Neurogenic shock is the shock that presents with bradycardia, and we'll be talking about that when we talk about spinal cord injury. Mocamam is a mnemonic for the treatment of increased intracranial pressure. So obviously you would monitor it. Patient's probably going to be in the neuro ICU. They get osmotic diuretics, and the most popular one is mannitol, and I'll talk about that in a little bit. They could also get hypertonic fluid like 10% dextrose because remember, hypertonic fluid is going to pull fluid from intercellularly to the vascular system. Okay, so you would watch for pulmonary edema, fluid overload to begin with, and then they'll start diuresing. Corticosteroids are used for like brain, if the increased intracranial pressure is for anything but TBI. TBI steroids are not used anymore. Patients are going to be hyperventilated after the first 24 hours if they're vented. The reason is when you hyperventilate somebody, remember they're going to breathe off a lot of CO2, so they'll make them alkalotic. And you want them to be alkalotic because having a PaCO2 too high is going to dilate the vessels in their brain and add to the increased intracranial pressure. All right. Antipyretics, I talked about not letting them have a fever. You want to correct that right away. Muscle relaxants, like we used to give a lot of phenobarbital to patients with TBIs when they were on the vent to kind of cool them off a little bit, so to speak, let their brain rest. Oxygen, and you want to maintain a PaCO2 30 to 35 because acidosis, respiratory acidosis, is going to vasodilate the vessels in the brain, and that's going to increase intracranial pressure further. Hydrocephalus means water on the brain. So basically, there's excessive cerebral spinal fluid in the ventricles of the brain. And so this can happen due to like somebody had a craniotomy and there was like blockage of CSF flow, or there's overproduction of it for whatever reason, impaired production of it. Those are the reasons hydrocephalus can happen. The treatment for hydrocephalus is to put in a ventricular peritoneal shunt, and it drains the CSF from the brain. It's usually put in the lateral ventricle of the brain to the peritoneal cavity, and it's just absorbed by the body. Now, which is good that they have this treatment, but the problem is it puts them at risk for meningitis and infection. So you have to watch out for meningitis. We're going to talk about meningitis, which can happen for many different reasons. So meningitis is an infection in the meninges of the brain. It could occur because of bacteria. It could be due to a fungal infection, which typically happens in HIV patients, or it could be viral. Okay, so we talked about the VP shunt. It could be after a TBI if it's open. Ventricular drains can also be a source of meningitis, and it's spread by droplets. So it could be, people living in close quarters is another thing that it could spread from. Patient will have high WBC with meningitis, and they'll, check cultures of the urine, blood, and throat. And also they will do a lumbar puncture, which I talked about in the assessment PowerPoint presentation. So look that over because you're going to need to know about a lumbar puncture. Signs and symptoms of meningitis can be remembered by the mnemonic it happens. Okay? 2. So seizures, because the meninges or are irritated, they'll have those meningeal signs, high temperature. They could be confused. They could be tired. They'll have a headache, altered mental status. They could have aphasia, photophobia, phonophobia is they don't like the sounds. Okay, so they like it quiet. Projectile vomiting, petechiae, especially if it's caused by meningococcal bacteria, they'll get a petechial rash. Emesis projectile, so projectile vomiting. Nuchal rigidity, we've talked about, that's a stiff neck. Nystagmus, remember that's the involuntary movement of the eyeballs. Sensitive to sounds, that's phonophobia. Tachycardia, because the body's under stress. And episnothosis, and that's when the body arches really. If you Google it, you'll see some cool pictures of that sign. There are 2 classic meningeal signs that you need to know, so they'll have a positive sign of each one of these if they have a meningeal problem. So the first one is Brzezinski's sign. So when they're in the supine position, you flex the neck. And if the lower extremities flex, that's a positive Brzezinski sign, okay? And then with the Koenig sign, that's another meningeal sign. With the hip flexed and the knee flexed, you can't extend the knee. So I remember it as the can't extend the knee is Koenig sign. Okay, so you need to know those two signs for both med-surg and pediatrics. Okay, generating solutions. So anybody that has meningitis, hopefully you can get a private room. They need droplet precautions. So recognize it early so you can get them away from other people. Seizure precautions for basically all the brain injuries that we're talking about. It is reportable to the public health department. You want to prevent increased intracranial pressure. If they do get it, you want to manage increased intracranial pressure. They're probably going to be on some kind of anti-seizure medication like phenytonin. They'll need acetaminophen, and an antibiotic as soon as it becomes available has to be a priority with bacterial meningitis because you need to try to halt the production of the bacteria. All right, now we're going to talk about brain tumors, and there's many different types of brain tumors. Primary brain tumors arise in the brain. They originate in the brain tissue. They can be benign or malignant. Benign tumors can be just as deadly as malignant tumors because they may be in a hard place for a surgeon to get to and remove the tumor, and it could keep growing and growing and put pressure on the brain, and the brain may herniate. Secondary cancers of the brain are due to metastasis. When patients have brain tumors, they're usually described as supratentorial or infratentorial. Supratentorial would include brain tumors of the cerebrum. And so signs and symptoms of brain tumors there, you would look at the function of the portion of the brain and, for example, say they had a frontal lobe tumor. They could have personality changes. They become really impulsive, okay? For infratentorial, that is the cerebellum, if it's infratentorial. So you would look for signs and symptoms such as lack of coordination, ataxia, okay? So the cerebellum can't do its job anymore, essentially. If the patient has the tumor removed and they have a craniotomy, if it's supratentorial, you're going to keep the head of bed 30 to decrease increased intracranial pressure. If it's infratentorial, you're going to put the head of bed 10 only, okay? And the reason is you don't want the cerebellum, if they're upright in the bed, to put pressure on the surgical site. That's why we put them in those positions. Recognizing cues of a brain tumor. So signs and symptoms can vary depending on where the tumor is. I'm going to give you the global signs and symptoms to keep it a little bit easier, all right? Okay, so you can use the mnemonic HAS, H-A-S. So headache, typically in the morning, gets better during the day. An altered mental status, like maybe they don't recognize their family anymore, or, that would be concerning. Seizures is another sign and symptom of brain tumor, and increased intracranial pressure. There's two conditions that can occur with brain injuries. One is DI, diabetes insipidus, and that results because the ADH that the brain usually secretes can no longer do that. So diabetes insipidus has nothing to do with diabetes. It means that the ADH in the brain has been turned off. So that means the patient is going to void and void and void and have copious amounts of urine. Okay, but we'll talk about that for the endocrine exam in exam 2. And they could also get syndrome of inappropriate ADH secretion. Again, those are endocrine problems, and we'll talk about them for exam 2. Okay, treatment for brain tumor can include chemotherapy, and they use this Ommaya reservoir and they put it in the brain because the chemotherapy doesn't cross the blood-brain barrier usually, and so they put it directly into the brain this way. They can also have a craniotomy to remove the tumor or debulk the tumor, and stereotactic radiation is a type of teletherapy that they could get. It's really precise, and they only have to be there for an hour to shrink the tumor, and they stay one night in the hospital. So it's lower risk than craniotomy and a lot less cost. Nursing interventions post-craniotomy. We talked about the position. Infratentorial craniotomies are going to be positioned at 10 degrees. supratentorial are going to be positioned at 30 degrees with the head of bed 30 degrees. You're going to be performing neuro assessments. So you're going to do neuro checks with vital signs Q 15 to 30 minutes for 6 hours after the initial ones in the PACU. And then every 1 hour times 24 hours. You want to report signs of increased intracranial pressure immediately. So know how to recognize those signs early. You're going to watch out for DI and SIADH, and then all those interventions to reduce increased intracranial pressure, like quiet room, no flexion, etc., is really important. Nursing interventions post craniotomy include, we talked about the positioning already, but you have to check the brain, the head dressing frequently for signs of drainage. You expect a small to moderate amount, so report like a saturated head dressing. They're going to have a hemovac or a JP drain for about 72 hours, so report drain output more than 50 mLs in an 8-hour period, and monitor for those signs of increased intracranial pressure. Steroids can be used to decrease inflammation in patients with brain tumors. So remember the side effects by the 6 S's, right? So with people with steroids, they are going to have high sugars because it increases the glucose in their bloodstream, and they'll have soggy bones. That's only if they're on it for a long time. They'll get osteoporosis. They could get sick. They have decreased immunity, so tell them not to go to, hang around with crowds of people, wash their hands, all that. It could cause sadness and psychoses, actually, steroids. Salt and water retention. So they could become hypertensive because of this, and they could gain weight because of this. They'll have a decreased libido, increased appetite, psychosis, I said, and a low potassium. So that's low potassium is really concerning. For phenytonin, it's highly tested. So make sure you understand the side effects, such as the increase in hair growth, enlarged gums. They need to visit a dentist regularly. Nystagmus and other cellular signs like ataxia, dysarthria, which means difficulty speaking, vertigo, diplopia. It's toxic to babies, or I should say fetuses, osteoporosis, osteopenia. It can also cause megaloblastic anemia, which is due to low folic acid absorption, and it could cause neuropathy. So remember that. It could also cause hyperglycemia. Warfarin, or I should say phenytonin, increases the effect of warfarin. So somebody probably shouldn't be on warfarin and phenytonin. And if women are sexually active, they should use another method of birth control than birth control pills. A TIA is a transient ischemic attack. So we used to call it like a mini stroke. It is a brief interruption of cerebral blood flow, and the patient will present to the ED like they're having a stroke. However, the neurodeficits resolve in 1 to 24 hours. The TIA is a warning sign. One single TIA indicates that that patient is a high risk for future stroke. So it's treated with aspirin. You teach them, to do all the things that are good for the heart. No smoking, no drinking, a heart-healthy diet, exercise daily, etc. When we talk about stroke risk factors, it's all the risk factors you learned with cardiac disease in MedSurg 1. So hypertension, diabetes, people need to maintain good glucose control, so you'll be teaching them how to maintain their blood pressure by taking their medications. People with sleep apnea that don't wear their CPAP machine can be more at risk for stroke. People with mitral valve stenosis, AFib, and endocarditis, they can form clots inside their heart, which can then travel to the brain. People with hyperlipidemia, people that are obese, people on estrogen replacement therapy or birth control pills, because estrogen has a high risk for stroke. People that smoke and drink too much alcohol. So in fact, you're supposed to tell patients that they can't drink for like 90 days after a TIA or a stroke. Strokes or brain attacks, also called cerebral vascular accidents, are placed into two categories. The first one and the most common type of stroke is an ischemic stroke. So the ischemic stroke could be thrombotic, which means there's narrowing of the arteries, or it can be embolotic. So embolotic strokes is, an embolus is um, detached from the veins or the heart, and it travels to the brain and gets lodged in an artery. Okay, typically this is AFib is a cause, or mitral valve stenosis can be a cause of embolic. With embolic, the symptoms are sudden. Anytime you have an embolism, symptoms are going to be sudden, okay? Hemorrhagic strokes, on the other hand, that's the other category, can be the result of hypertension. Sometimes people who stop taking their medications, their blood pressure medications, have like rebound major hypertension, or people that do cocaine or methamphetamine, those are stimulants that raise the blood pressure really high. They can have a hemorrhagic stroke. Some people that are born with aneurysms, aneurysm is a outpouching of the artery, and it's weak. Okay, so if the blood pressure over time keeps increasing, the aneurysm gets weaker, and they could have a subarachnoid hemorrhage. Same with an arterial venous malformation. Sometimes people are born with these, and they could be born with them and have them and be healthy all their life. Or if they have one, at some point they may have a subarachnoid hemorrhage. One of the causes of embolic stroke is atrial fibrillation. So with atrial fibrillation, you're going to see an ECG with no discernible P waves. Okay, there'll be squiggly lines. So it's a fibrillation, atrial fibrillation. The rhythm is going to be irregular, sometimes referred to as irregularly irregular. Okay, patients are going to have a pulse deficit if they're in AFib, so you're going to check for that. And remember, you need two nurses. Remember how to do that. But this is going to result in sudden neurodeficits. And when we're talking about ischemic strokes, they're the type of stroke that occurs without a change in the LOC. Another cause of embolic stroke is endocarditis, which is an infection of the inner lining of the heart. And these vegetations, bacterial vegetations, form inside the heart. And it can dislodge and become an embolus and go to the brain. So it can affect the heart valves as well. So that's a factor. And endocarditis can occur in IV drug users, people that just had a heart attack, people that have procedures like a pacemaker, they can develop endocarditis as well. Another cause of embolic stroke is heart valve replacements. The patient is going to be on most likely warfarin or some other anticoagulant, but they keep the INR higher than the normal 2 to 3 when we put people on anticoagulants. Mitral valve stenosis is another cause of embolic stroke. Thrombotic stroke is like 50% of the ischemic strokes, okay? So thrombotic stroke has a slower onset of symptoms, and it's due to blockage of the arteries supplying the neck or head, okay? The LOC is typically intact with ischemic strokes. Hemorrhagic stroke often presents with a change in the LOC, and it can be due to an intracerebral hemorrhage, which describes bleeding into the brain, usually from severe hypertension, or a subarachnoid hemorrhage, which we've talked about before. It's the worst headache of their life. The bleeding is into the subarachnoid space, so they're going to have those meningeal signs. And you can remember the risk factors for hemorrhagic stroke as with the mnemonic HATS. So people with hypertension, maybe they stop taking their antihypertensive meds, and now the blood pressure has rebounded, and they can come in with malignant hypertension. Anticoagulant therapy makes them more prone to bleeding. Trauma can also cause a subarachnoid hemorrhage, because that's why it was in the brain TBI portion of this lecture. And substance abuse like cocaine, methamphetamines, so stimulants. can cause severe hypertension. With subarachnoid hemorrhage, it can be due to an aneurysm that bursts due to hypertension or an AV malformation. And there's some pictures on there so you can get a visual of what that looks like. You want to teach patients to exercise daily to prevent stroke, stop smoking, and limit alcohol. They need to eat a heart-healthy diet. They shouldn't do cocaine or methamphetamine. And estrogen is going to put people at a high risk. I took care of somebody that was 26 on birth control pills who had a stroke. So young people on birth control pills are prone to DVT and stroke, and tell patients to maintain a proper weight. As a nurse, you would teach people in the community the warning signs of stroke with the B fast mnemonic, because it's an easy way for patients to remember. So B stands for they have a sudden loss of coordination or a severe headache with unknown cause. If they have dizziness, trouble walking, loss of balance, or coordination, they should get to the ED. Call 911. With the eyes, it's a sudden loss of vision in one or both eyes. And then for F is for face. Does the face look uneven? Is their facial drooping? That's something you will be looking for. A is for arm weakness, so a sudden or gradual numbness or weakness of the face, arm, leg, especially if it's on one side of the body. With speech, they could have trouble with receiving information or trouble speaking information. So that's your Broca's and your Wernicke aphasia, which I talked about in the assessment lecture, and you're going to have to know that definitely. And then T stands for if you have any of these symptoms, it's time to call 911. When doing a stroke assessment, there are some priorities. Per the Joint Commission, you have to have the National Institute of Health stroke scale or whatever stroke scale your facility uses. You need to do that within 10 minutes of admission. And the reason is when somebody has an ischemic stroke or a thrombotic stroke, you only have 4.5 hours from time of symptoms start to get the thrombolytic therapy starting. Okay? Within 25 minutes, you're going to get a non-contrast CAT scan. They do non-contrast because a hemorrhage shows up as white on a CAT scan, and so does bleeding. Okay? So the reason they do a CAT scan is not to necessarily diagnose a stroke, it's to rule out a hemorrhagic stroke because people with hemorrhagic strokes are not going to be given thrombolytics. Anybody that has a change in their LOC or a change in their neurostatus, you need to check a glucose and O2 sat because those are two easy fixes. And oftentimes these two things, if the glucose is low or the O2 sat is low, can the person can present as same symptoms as having a stroke. And also get a history because you want to know when the symptoms first started because you only have 4.5 hours to give thrombolytics. When you're taking history, find out if the patient is taking any herbs. This is a perennial favorite of ATI. So some of the herbs that can cause bleeding include feverfew, and people would take this if they have migraine headaches to prevent them. Saw palmetto, people with men with BPH, benign prostatic hyperplasia. You'll learn about that later in the semester. Saw palmetto can increase bleeding. Ginkgo can boost memory and cognitive ability, so people take it for that, but that can increase bleeding. Glucosamine, people take that for osteoarthritis. Garlic they take that to lower cholesterol. Ginger root is for digestion and nausea. And then golden seal is for digestive problems and skin disorders. But those are the reasons people take these herbs. So you might have to do a history to see if they're taking any of these, if they come in with stroke symptoms. There's a few key players on the interdisciplinary team for care of patients with stroke. The first and most important one is the speech language pathologist. So when your patient comes in with signs of stroke, you keep them NPO, this is super important, until a swallowing study is done by the speech language pathologist. They can also help with language problems like the aphasias they can incur with the stroke, but you don't feed them until the study is done. Physical therapy, they can help resume ambulation. It depends on the severity of the stroke. They can help with assisted devices like walkers, quad canes, and wheelchairs. Occupational therapists can help with the ADLs, and social services can help with maybe after they're discharged from the hospital, they need to go to a rehab hospital, and also help with referrals in the community that can assist patients post-stroke. The symptoms of a stroke can be put in two different categories, like the right brain damage versus the left brain damage. So a lot of times we say they have a left-sided stroke, which means the brain is affected on the left side. So that's where the stroke was, the left side of the brain, which results in right-sided hemiparesis, which means right-sided weakness, or hemiplegia, which means right-sided paralysis. So patients with strokes are going to have symptoms on the opposite side of where their stroke was. So if they have right brain damage, so that means their stroke is on the right side of the brain, they are going to have things like left-sided neglect. They'll be paralyzed on the left side or have weakness or hemiplegia, so that's paralyzed. They tend to deny or minimize problems. They may not recognize family members. They get very impulsive and do crazy things. They also do not have a sense of proprioception, so they are at high risk for falls. They have a really inappropriate sense of humor. They are impulsive. I think I said that. They have impaired judgment, and they lack awareness of their deficits. They may confabulate to fill in the gaps. They may, exhibit feelings of euphoria, like constant laughing or smiling. So they also lose the ability to hear vocal tonal variations. Whereas on the left side, so that means a left-sided brain damage, the stroke is on the left side of the brain, they're going to have contralateral weakness or paralysis, so that's hemiplegia on the right side or hemiparesis on the right side of the body. They'll have impaired speech and language, so they'll have the aphasias, Wernicke's and Broca's, so make sure you know the difference. They're going to have impaired right-left discrimination. They are slow, conscious, and they also get very frustrated, so they have a feeling of powerlessness. They know their deficits. That's why they get anxiety and depression. And they may not be able to read anymore. They may not be able to do math anymore. So acalcula is the inability to do math, and aphasia is the inability to receive information, or also have motor deficits of talking. They can't talk anymore. Agraphia means they can't write anymore. So they have all the A things. That's how I remember right versus left. After a stroke, a patient may have problems in their visual field, like with blindness. So I'm just going to keep it real simple because there's all different forms of this, okay? So it's called hemianopsia, okay? So if they had a right brain attack, they're going to have deficits in their left side. If they had a left brain attack, they're going to have deficits in their right side of vision. So just like the weakness and the hemiplegia, it's going to be opposite of where the stroke was in the brain. Okay. So a couple of things you can do is approach the patient from the non-blinded area. So approach them where they can see you in the vision, place items in that field of vision. So I'll give you an example. Somebody who has right-sided hemianopsia had a left-sided brain attack. You want to approach them from the left side and put all their belongings on the left side. So like the trick question is, a person had a left-sided brain attack, or the person has right hemianopsia. Where are you putting the bedside table? Where are you putting railings in the bathtub? Things like that. So be thinking of that. You want to teach them to scan their environment. You want to make sure their dinner plate is in the right visual field. When I say right, I mean correct visual field, depending on which type of brain attack they had. Some of the interventions you can incorporate into care for patients with aphasia is provide time to respond, reorient them frequently, only give one instruction at a time, and be patient. In the picture board. So remember, if they have Wernicke's aphasia, there's damage in the left temporal lobe. So they cannot process words or understand words. So they have receptive aphasia. They can talk. If they have Broca's aphasia, this is damage in the left frontal lobe, which helps with the motor aspects of speech. So if that area is damaged, they have effective aphasia. If they have both, it's called global aphasia, and the speech language pathologist will help with language. Remember how to prevent aspiration pneumonia in patients with dysphagia. So the speech language pathologist is going to recommend a diet, and that's the kind of diet you're going to feed them. Make sure they rest for 30 minutes before eating to prevent aspiration. Make sure you offer oral care before and after eating. Oral care is a great preventative of aspiration pneumonia because it cleans out all the bacteria in your mouth, and you don't want patients to swallow their saliva with bacteria in it and then aspirate. Patients should only be focused on eating when they are being fed. So they shouldn't be watching TV. They shouldn't have a lot of people in their room. They need to concentrate on eating. You're going to feed them on the unaffected side, so the side that's not weak. 1 teaspoon at a time. Do not allow them to drink and eat at the same time, and definitely no straws because they can't control what they're taking in with straws. You want to encourage them to put their chin to the chest to swallow and move their head and neck forward. Head of bed needs to be 90, so don't feed them supine. 90 is the best position, so fully upright. Keep upright after eating 45 to 60 minutes. If you're going to provide oral care, don't put your patient on their supine. Put them on their side. Have the suction ready. And you should have the suction ready on all stroke patients, not just when you're feeding. One of the first things you do in your shift is make sure that suction is set up, but more importantly, make sure it's working. That is my pet peeve. I can't tell you how many times during a code, the suction was in the room, it looked like it was put together, and when the nurse went to turn it on, it didn't work. And you don't want to be in that situation, especially as a new grad, because it's going to make you super nervous and you're going to be anxious, and then that's going to further impede your ability to get that suction set up and ready. And you can use a padded tongue blade to open the mouth. I know padded tongue blades get a bad rap because we don't use them in seizures anymore, but you can certainly use it for oral care. Post-stroke, patients are going to be at risk for increased intracranial pressure for the first 72 hours. So you're going to do all that medication that's typically given if necessary, and you are going to monitor for increased intracranial pressure for the first 72 hours. So all those interventions like placing the head of bed 30, no flexion, etc. You're going to incorporate all those into the care. Now there's certain medications that patients with strokes get, and aspirin and clopidogrel, the antiplatelet medications, are given to patients with ischemic strokes only. And you don't give within 24 hours of the thrombolytic. So they would get them 24 to 48 hours post-stroke. Antithrombotics, so that's like your TPA, and these would be given to patients with ischemic stroke, so they've already had a CAT scan, and they're going to be on bleeding precautions. So remember, all your interventions, the same interventions for thrombocytopenia, are the same interventions for antithrombotics. Heparin and warfarin is also given usually in patients who have AFib. This is to prevent clots from forming inside the heart. So they'll also need VTE prophylaxis, which heparin and warfarin would help with. Nimodipine is given for subarachnoid hemorrhage. It prevents rebleeding in the brain. It's a calcium channel blocker, so it's going to vasodilate, and this would be given to people with hemorrhagic stroke. You hold calcium channel blockers for systolic BP less than 90. Nicardipine is another a calcium channel blocker that promotes vasodilation for both stroke and high systolic blood pressure. So that would be given for ischemic or hemorrhagic strokes. Stool softeners to prevent valsalva remover or straining with the bowel movement definitely needs to be given. And then statin medications for patients with hyperlipidemia. They should be discharged on a statin if they've had ischemic strokes.